Okay, I'm delighted to have Richard Collins, who's a Programme Director, and Sarah Newcombe, CNIO from Great Ormond Street, here to chat with us today and share some of their experiences about implementing EPIC, something that's very close to all our hearts at the moment, with an impending launch of Encompass here in Northern Ireland. So today is really about learning from people who have had experience of a practical implementation in their areas. So I'm sure you'll all have loads of questions. Do feel free to put them in the chat, and I'll hand over to Richard and he can start the presentation.
Linda, thank you very much. Okay. So yes, thank you for the introduction. So I was the Programme Director at Great Ormond Street. I'm sure Sarah will give you some of the history of our go live, but I also more recently helped implement the same system shared with GOSH at the Royal Marsden. So most of what we're going to talk about is our experiences at GOSH, but we'll also give you some of the learnings from the Royal Marsden go live as well. I've fully recognised that the implementation at GOSH was and is going to be very different to your experience for many different reasons. You're a very different organisation. You're very complex in terms of the programmes that you're doing, but hopefully, if not everything resonates, then certainly some of the things that we talk through might resonate, and we're more than happy to answer questions, as you say, at the end. I will hand over to Sarah.
Thanks, Richard. Hi, everyone, and welcome to the EPIC community. You're certainly on a journey, and it's an exciting one, hard work, but definitely an exciting one. So I'm Sarah Newcombe. As Richard said, I'm the Chief Nursing Information Officer at Great Ormond Street. I've worked in various operational roles over the years through Great Ormond Street with a background in intensive care nursing, and really to this day not quite sure how I ended up on the CNIO role, but we're here today and I've enjoyed every minute of it, haven't I, Richard?
Yes.
So just to tell you a little bit about GOSH, so just to give you the background, because I know, as Richard said, we're quite different, but we are a tertiary quaternary referral centre just purely for paediatrics, and we're a big research and teaching hospital. And over the last few years, we started off in quite a low digital maturity state, and so we were quite keen to move ourselves up that ladder, and EPIC became one of that journey. We also have something called Drive, which is our innovation hub, which is the digital research innovation virtual environment, and we do lots of sort of ideas work, virtual ward pieces over in there. We like to refer ourselves as small but mighty, so we see approximately 240,000 outpatients a year. We have 63 clinical specialities, and with about 400 inpatient beds. And with that, we've now, I just had a look, actually we've got 5,400 staff within our organisation. So, you know, quite a number of people. And we've just recently, in the last month, completed our 500th cardiac transplant, which has been quite a celebration for us as a team. Next slide.
I thought I had. It is on my screen.
There we go. So when we started our EPR journey, it was really clear for us that we wanted this to be a clinical transformation programme, and not an IT project. I think, you know, that historically as an organisation and culturally, things have been done to the organisation in terms of just implementing systems without any clinical involvement. And that was a really big remit of my role, is to get the clinical teams involved so that we had what we wanted and what we needed to do our jobs. So it had to be owned by the organisation, and not done to the organisation, with a clear focus on patient safety. And so we went right at the beginning with a mild wide inch deep. We were going across the organisation, and just going to do it an inch at a time. You can imagine some teams wanted to go a little bit deeper, but we managed to hold them at bay, and keep it as that sort of just getting it in across the organisation, getting people used to the system, and then allowing them to develop from there. Thanks, Richard.
So just picking up on a number of different sort of subjects, the first one being leadership and culture in terms of what we needed to be successful at Great Ormond Street. I think it goes without saying, leadership from top down is absolutely critical, and you've got a lot of different leadership within your program, given the different organisations that are involved. Obviously, we were small and mighty, and that made it easier, I think, in some instances. But we had really good support from our executive teams. Culturally, Gosh was quite an interesting organisation when I joined. It was quite insular because of its tertiary quaternary nature. It hadn't done much change, and actually I think we were quite nervous, anxious about whether the organisation was going to be able to adopt this whole new way of working. There was definitely a lot of desire for it, given we had a lot of disparate systems. We felt we delivered great care, but the way in which we were able to interact with the patients wasn't as good in terms of some of our data and systems. So overall, I think from a leadership and culture point of view, we set ourselves up reasonably well. I'm going to show an implementation governance slide, which looks a bit complicated, and your governance will be possibly even more so. But just to say, we set ourselves up as a programme, with obviously overseen by our trust board, and with a programme board that was chaired by our SRO, who started off as a medical director and partway through the implementation became the chief exec, which again was very useful to us. We had a great relationship and still do with Matt. And then we had a number of different groups working to support the programme, different levels of operational engagement at each, and our steering group was chaired also by an executive. So as I say, they were very much involved in all of the working groups that we had within our governance. Our experience, so our exec team felt really that they were fully sighted on what was happening, and what that meant was they trusted us to deliver the detail, and they didn't necessarily try and get involved in that other than where we needed to. The reason why that's important, and I've seen it on different implementations, execs usually try and be present, particularly at go live, but people also collar them when things aren't quite going right, and there is sometimes a risk that execs come up and escalate things which don't really match all of the priorities of what teams are trying to do to fix. We didn't have that at Gosh. Actually, we were well supported. We did a lot of practice, and there's a few slides. We'll talk about what some of that looked like. We did a lot of practice before we went live to try and show people what it meant to go live in terms of the governance, the management, and the support. And we did the same at the Royal Marsden, and both of those practice events had a lot of benefit. People in operational clinical leadership roles felt that they had an understanding of what was happening to them. Gosh had a view that it was, one team. That was part of our culture. I don't know that we always display that, but certainly at Go Live, that was something that we did have. The organisation pulled together. It was quite remarkable, and that really helped, because the first few weeks of any Go Live are really challenging. It doesn't matter how good you prepare, it is really difficult to take organisations through this level of change, and so having that everyone pulling together mentality is really important. And we didn't just have that within the trust team, we had that with Epic, our supplier, and we had it with partners who came and joined us. So advice, and I've put that as a question mark. I mean, these are things which obviously you'll have to work out yourselves, but I definitely think it's important that the exec teams are part of the planning for Go Live, so that they also understand what it's going to look like. You have to have clarity. There's a lot of different teams involved, but clarity on who's going to be responsible for what. The Encompass team, other colleagues within BSO, obviously Epic, and then the individual trust teams. So Southeastern obviously going first, and hold to the plan. So when you set your plan about what Go Live is going to look like, who's going to be doing what, hold to it unless everyone agrees that there's something that needs to be done differently. And at Gosh, what we found was after the first couple of days, we needed to have something other than the gold, silver and bronze. And so we instigated a huddle with the chief exec at 5 o'clock. And that didn't, it didn't override all the other governance, but it did give us a different place to come and talk about issues that we were having and get guidance from our execs. So that was the only change to the governance we made. There will be hundreds of issues, probably thousands. Epic will give you detail on the number of tickets that always get raised at go lives like this. It's really important, obviously, to prioritize which ones you deal with first, and be very careful that individual different teams don't become fractured. It's very important that there is a common goal and a common voice, and everyone pulls together. Sarah, end user engagement.
Yeah, I think it's really important, Richard, as well, to say at that point that, you know, go live is just the start of the journey. It's not the end. And I think, you know, most people think that everything's going to stop once you've gone live and they're not going to get any help. And so they want you to sort of be doing everything and fixing everything in that run up to go live. And it's just about keeping that calmness and keeping that, actually, what we're going to do is what we've planned, stick to the plan, and we will then develop post. And people change the way they use the system once you've gone live. So that's really, really critical. And user engagement pretty much became my passion and my bag, really. I spent a huge amount of hours on out in the clinical areas, and I think for me that was really how we did the best part of our engagement of staff. We set up lots of sort of user forums and things for people to join, but it's not that easy getting clinical staff out of areas. And one of the key things for me was really understanding what current workflows were. I'd worked operationally across the organisation. I was a clinical site practitioner for many years, so I had actually got the experience of working in all ward areas. And you think you know how people are delivering care. Actually, it's quite surprising how different it is, and how many different numbers of ways of doing things there are. And you're bringing in a level of standardisation across the organisation by you know, not really by choice, but by the fact that you're implementing this system. So it was key for us to sort of really get engaged and really understand what people were doing, how people were working currently, to then sort of mirror and match and get people aligned into the system. So as I said, we did lots of roadshows and events, but the best was going out to the wards and spending that time, putting a uniform on, rolling up the sleeves and really listening to people's fears. One of the challenges really is the prioritisation piece, because it's not on everybody's radar. When you've got things like winter pressures and other things going on within the organisation, people's priorities change. And for us, Epic seems such a long way in the future for people. They just couldn't get their head around having those discussions. So, you know, making a nuisance of myself became, you know, a good part of my career, appearing in every single meeting that people had. So testing was also really key, and I think one of the big things that we did was we actually got people to create their own testing pathways. So we went out to the organisation and we said to the nurses, tell us what it is you want to do in order to deliver care to your patient, and we will create that workflow. It wasn't just a workflow built by Epic, it was a workflow built by the organisation, so they got it straight away and they could understand what some of those challenges were going to be. The go live readiness assessments were always good. It gave people the opportunity to ask questions, and it really was the key to our go live in terms of getting our teams on board. We had an away day for our ops leadership, and I think that was also a key turning point, because they started to get it, taking them off site, getting them into a room and having honest conversations, hearing people's fears was actually really, really helpful. And, you know, you think you're doing comms really, really well, you get all the posters, you spend a huge amount of time doing it, but actually the reality is that people just don't always have the time to read emails, and certainly not read them into the detail that you need them to. And so it really important thing is getting out there and having those conversations. And I love the way Richard's put the question marks around advice. I mean, I think we would give advice, but you know, for me, it is remembering to celebrate. It's a massive achievement for the organisation. You will get there, but it is an enormous amount of hard work and graft to get to that point. But if you get everybody on board believing that they're going to the same you know, the same target, the same end, and that is to have, you know, better patient workflow, better visibility for your patients. And, you know, we got patients and family involved right from the very beginning so that we could bring them along that journey with us. And that was also really helpful to get some advice from them as to understand how that might impact for them. So things like the patient portal, They brought huge amounts of detail to that so that we could really get that up and running and working so it was used and utilised. And we have huge, statistics now. We have 95% of our oncology patients are using our portal. We call it My Gosh. I'm sure you call it something different. So that was really, really good for us. And make sure there's a forum for staff to bring their concerns. So we sort of put ourselves out there. We put ourselves in meetings. Sometimes people would turn up, sometimes they wouldn't. We did things in the canteen. You don't want to disturb people when they're having lunch, but actually getting people out of the questions is really good. And as many of you know, nurses will never say no to chocolate or sweets or anything along those lines. So we weren't shy about bribing and taking gifts along the way. And it, every time we went, used to come, oh, what chocolate have you got today? So that was a really good point. And, it became that real good engagement piece with people to just kind of have those conversations and, reward staff. And this is just some of the comms we did, and that was the sort of meeting with our operational leads on the left-hand side that we put together. Kirsty, our comms lead in the middle, did an amazing job. We did lots of sort of monthly road shows. It really is just about, so we lit the hospital up, I think would be a really good describe. We turned it pink, with all our posters. Towards the end, we had them on lifts. Our lift doors didn't look like our lift doors anymore. They had EPR all over them. So anyone who didn't know what EPR was, they certainly did by the time they'd walked through the hospital.
And just to say, the other person with Kirsty in the middle, Adrian, is now the program lead.
Oh, of course, yeah.
CHI. So doing the same thing now in the south.
So training is another key area that we got quite passionate about at Great Ormond Street. I personally don't believe you can teach people or train people to use Epic. I think you deliver familiarization. So you have to give them a level of training. For our nurses, we did 8 hours of training. And that really is a familiarization of the system, what it looks like, how to navigate yourself around it, where to find the things to just deliver care on the day of go live. And I know most of the nurses today say that they have learned to use Epic since go live, and that they now love it. They love the way it works. They love what they can do with it. They can personalize it, and it's a great workflow. But that training piece is quite hard. I think we this is Helen Vine, who some of you may know, who was our EPR program manager. Did an amazing job for 2 weeks solidly to build the training program with, as you can see, thousands of sticky notes and bits of paper that actually put our training together. Don't underestimate the training piece to get the whole organisation out and forward for training. We trained 4,500 staff. We were really lucky in that our chief exec had a very clear stance at the beginning that said that if you had not had training, you didn't come to work. So we were really proud of the fact that we had, I think it was 98% of our staff were trained pre-Epic Go Live, which was a huge amount. The rest were maternity leave or various other things. But it took 2 weeks for us to pull that all together. Yeah, I think Helen's tip there is to stick with Excel.
I spent 2 weeks, Sarah, too scared to go into my office, because every time I did, I knocked a post-it note off one of these important pieces of paper that ruined the whole of the training schedule. So I would definitely not do it on paper with sticky notes again.
No. One of the biggest challenges as well, I think, is at that point is around your ESR or your current organisations. What I hadn't realised or hadn't anticipated when we went into this was how many different names there were for a nurse role. So clinical nurse specialists, nurse consultants, lead nurse, sisters, specialist nurse, AMPs, ACPs. You've got to work out within Epic what label they're going to get in the system so that they get the right place to be. And so that was really quite a challenge because we didn't really know. We had hundreds and hundreds of labels for staff. So it's really, you need somebody who knows what how your organisation works to understand what those roles are so that people get the correct profiles. Users and security is one of the things that causes people the most stress at Go Live, because people don't know whether they've got the right screen or the wrong screen. So it requires someone who knows the Epic workflows and the Epic work to be able to do that. We decided at Gosh, and I'm really proud of the fact that we did this, to take on the education and the training piece of Epic ourselves. So we brought it into the nursing leadership. It went through nursing board. I delivered a number of papers, and we got the commitment from the directors and heads of nursing to release staff, particularly for the super user role and that supernumerary status at Go Live. It's really hard to explain to a ward that's really busy that you need supernumerary staff on those days to help staff work through that Go Live piece and how they document things, how they deliver medication. Everything is so different from doing it on paper to moving into that digital space. We really wanted to take the ownership for that. So we, as I said, we used our education team. They were a huge bonus to us. We got education leads in each area, and so they took on that roster of developing a roster for our teams to put names on those that were going to be supernumerary on those shifts. Like anything, that was a challenge. We had ward areas who weren't, up to their numbers, and so they found it difficult because there were gaps in nursing already. To then put forward others that were going to be supernumerary was impossible for some areas. What we did in those cases was set them up with their own little area to do playground, which is the practice within the team. We decided quite early on within nursing that there needed to be a clarity on language. As many of you probably know, Epic, being the American system that it is, still uses quite a lot of American terminology, and we tried to sort of bring that into the UK so that everybody understand and there was clarity on what the difference was between people. The recommendation from Epic is to have floor walkers and super users. We removed that and we just called everybody floor walkers, and so everyone was the same title and it didn't cause confusion for anyone.
So I think Sarah's talked to a lot of this already, and conscious of your time, but I guess the key things, we really did struggle with our staff data. I think everyone has. So whatever you can do to try and work out who needs training and in what role, that's definitely something I think I would focus on. We benefited from the specialist training specialists, which is medics training medics. We probably could have done more of that for some of our other teams. So despite what Sarah says about nursing, I think generally we probably could have focused more on having specialists supporting that. I think we didn't do enough training on the technology and the new ways of working. And again, our staff struggled a bit, because when they started to use the system, they were using it not just a new system for documenting things, but where they did it and what tools they used for doing it was very, very different. I think that, as Sarah said, people won't be experts. Just recognise that and make sure they recognise it. There's a lot of anxiety for people when they're changing and going to a new system. They think they need to know everything. They need to know that that isn't the case, but we will need to support them in the early weeks after Go Live, and whether that's super users, activity reduction, or whatever process you make sure that the staff don't go into this expecting to know everything, because that really does increase their anxiety. And make sure people, when they come out of their training, ask themselves the question: do they now feel comfortable knowing how they will use the system in their job? The answer might be no, but at least that's something that it's worth asking.
I think one area there, Richard, as well, that we weren't so great with was supporting our admin teams. I think they're quite a difficult group to target because they don't sit in one area. They don't have a group team meeting that you can sort of crash. They tend to sit within their directorates or within their operational teams. So it's quite hard to target them in terms of that whole scheduling piece. And so we definitely saw some issues in that area that were challenging. Is it me support as well, Richard? So yes. It's like the Sarah show. So super users, we spent a huge amount of time and we're really lucky to be able to go to other organisations who had implemented Epic before. We pride ourselves in making friends and we went out to the US and spent some time at other go lives. I was lucky enough to go to the go live in Beirut, who the team over there did a phenomenal job. And while we were over there, that's where we got the idea for the super user jackets or waistcoats. And any of you who know our CCIO, he's famous for wearing waistcoats. So that was his thing that he really wanted, was everyone to be in waistcoats. So it actually worked really well. So we had all our super users across the floor. We had many international super users who came to support us, and we were very grateful for their help. We were one of the first to go live with Epic in the UK, although Cambridge went before us in 2014. UCLH were going really 3 weeks before us, which was the same time. So we didn't have a group of staff we could pull on to help. What we did create were the communication channels was around the super users daily briefings. So we made that we'd got targeted so that people could come along and talk. We did it in the morning handover, 7:30 to 8 before shift starts, so that we could tell of any issues that had cropped up overnight, and that people could then take any learning out onto the ward straight away. And again, we did the same thing because we do 12-hour shifts in the UK, that we did the same thing in the evening at 7:30. That worked really, really well. And then the morning briefings for outpatients were sort of 8:15, and we did these on a daily basis for 2 weeks, and that really helped the team sort of settle in and have that place to go to with any issues that they had. And this sort of really just talks about, we made some friends, but for many trusts, external help is invaluable, and we've learned that. We've supported a significant amount of go lives following that. I think I'm about 8 up to date now that I've done, and looking forward to supporting GSTT, which goes to St Thomas's in London, that will go live in October of this year. I think it's really important to have people who aren't just familiar, because the super user training for your internals is only really one lot of additional training to what they've already had. So again, they still don't have that in-depth knowledge that people like ourselves now, who've used the system for 5 years, can have and talk and find the things that people need to find. So you really do need to sort of get in early and get that external help. It will be invaluable to you, and it's certainly helped the Royal Marsden team. Again, we were on site for their go live in March this year, supporting them at the elbow, and it makes a massive difference for teams. It's also a really good opportunity for us to get ideas of how other things have been built in the community, the Epic community, and we've learned a lot. We brought things back from the team in Manchester, and you then become part of this community that really does help you create a really great workflows for you and your patients. Look, Richard's putting there, you're going to invite all your friends to Belfast. I've never been to Belfast, actually.
I have. It is a lovely city, and I do think that you'd be amazed, particularly American colleagues, how keen they are to come out. They give their time for free. We ended up paying expenses, so flights and hotels, but the value that they added, and we had the same both at Gosh and the Royal Marsden. Definitely do try and make friends, not just with the NHS community, but more widely than that, if you can. Do you want to pick up on workflows, Sarah?
Yeah, happy to. I think, I alluded to it a little bit earlier on as well, but the workflows is really about understanding what your workflows are. There's a piece there for me around kit. Epic are quite keen for you to decide what kit you want quite early on in your journey. What you really need is somebody out there clinically who will understand what the Epic workflows will be, so that you get your kit in the right places, so that at go live you've got kit where it needs to be and not where IT think it might need. And usually that's just because there's a plug socket handily available. So we spent quite a bit of time doing that. In fact, I actually redid what IT had done just so that we got a better understanding of that. These are just some pictures again of the workflows that we created, and the picture on the left is the scenarios that I was describing earlier. Create your own, and then we brought teams in the middle to do some of those scenarios and test them and pass them for us. And then also this is just us on the ITU, some consultants going through the workflow for them and getting feedback. It's really invaluable actually to make sure that, again, this is another engagement piece, getting people on board and feeling like they own the system too. So that phase went really well for us, and we did some good testing. We still weren't perfect. We still had some challenges, but I wish we could have done more of it. It's never quite enough. I think would
Yeah.
be fair.
And I think, I mean, that's EPIC obviously focus. I mean, there's a number of testing phases that happen, but application and integrated testing, which make sure that the build of the system is supported. We did workflow testing, as Sarah's talked about. We didn't do enough, and we didn't do enough at the Royal Marsden either. And one of the issues that we had was really focusing on not the wrong thing sometimes, but not focusing on everything and having that big picture and making sure that the system actually works in all of the areas that you're going to have to use it. We did have empty wards at Gosh that was really helpful. As Sarah said, I mean, we practiced. At one point, I was trying to get somebody to take my blood so that we could actually run it through the labs, but we didn't quite go that far. But the idea was that we wanted to do enough scenario testing to work out how we looked after a patient, including the kit we were going to use at the bedside. Shadow charting, this is a really great idea, particularly EPIC push it in theatres for the anaesthetists, and it, you know, we've done it both at Gosh and the Marsden. Both of those teams felt really confident with the system. We did tiny bits of shadow charting, and this is basically where you do have patients there and somebody documents in EPIC at the same time as someone is documenting in legacy systems. We didn't do enough of that in other areas, and I think had we had our time again, we would have done more of that. One of the real challenges actually is just time available for both, in your case, the Encompass team, but also colleagues, operational and clinical colleagues, to make time for effectively practicing in the system.
I think one thing just to add there, Richard, as well, we now have a fantastic simulation team at Gosh. Back in 2019, it wasn't established in the same way that it is now, but you may already have that, and they now run with it. So any new development or any workflows that we have, I now run through our simulation team, and they then work through and get a load of groups of teams in to see what the development will be and get feedback. I think if we had that opportunity again, using the simulation team would be amazing to get your teams out and get staff in. And that's just running through resus scenarios, you know, giving blood, taking bloods, all the sort of points where it becomes a bit of a challenge and people become a bit fearful of EPIC. To get people running through those is really, really helpful. And we do a lot more of that now than we did at Go Live.
Yeah, and I think the last thing, which perhaps is an obvious thing to say, you can only build so many workflows. They won't meet everybody's needs. There'll be ways in which people do things that it's quite right to be different, but that won't have been thought about. I think just recognise that will happen at Go Live and be prepared to support those staff when they find that the system has been built doesn't quite meet their needs. Clinical risks, Sarah?
Yeah, sorry, I was waiting. That's it. So clinical risk, I think one of the big things you will have known, do you have in Ireland the clinical safety officer role in the same way that we do in the UK, which is the expectation that you do a clinical safety case and create a hazard log for implementation of digital systems. So there is a requirement for us to do that in the UK. EPIC create one half, which is the supplier side, and we created the bit for the UK. That really is the piece around understanding what some of those risks might be, and we pride ourselves on the fact that we try to anticipate some of those. A lot of that was, work and talking to other organisations who'd done it before and listening to what their lessons learned were. And we tried to sort of pick some of those up. And Richard, if you just move on to the next slide for me, please. This is just one slide of our top expected issues. So we generated expected issues before Go Live of what we knew might be a problem before we actually got there, and these were just what other people had told us. So the blood transfusion workflow, still a fear factor for every Go Live I've been to since. What we did there to try and mitigate that risk was we created what we call a blood SWAT team, and that's nothing to do with my affection for Colin Farrell from the film. But actually, it was really, really helpful, and it just gave colleagues the opportunity to call the number that we gave them, that they would then have somebody who had gone through the workflow and would stand by them and watch them do the workflows as they administered the blood. And that, provided our transfusion team also with some confidence that we were we were doing this right. Medications as well was also another area, and again we instigated these sort of SWAT teams across, and I think, you know, one of the challenges is that it becomes really paralyzing at Epic Go Live. You know, I remember being on the wards, and one of the nurses said to me, she said, I need to do some obs. I said, well, that's okay, you can do the obs. And she said, well, I've documented them. Okay, that's fine. What do I do now? And it's that whole piece of people just get so obsessed with the system and the wow and the barcode scanning and everything else that they forget actually they're just there to deliver care. And the system is just a different way of documentation.
So I'll just go through these quite quickly, and we've done some of them. So some top tips. Obviously have a clear plan for how you're going to escalate. So whether it's a bronze, silver, gold kind of structure, but make sure that's clear at the outset. Engage strong leaders. We were really lucky at GOSH and at the Marsden. We had really strong medical information officers, nursing information officers, supported at GOSH by Sarah and Shankar, who you can see in the picture. We did practice. We tried to keep patients informed. I think most patients would say they were informed. Super users, we empowered them. We allowed them to go and support the end users without constantly having to come back to us for clarification. And remember the corporate teams, finance, HR, they are often very eager to help, and there are roles they can perform. So it's worth remembering them. And Sarah's ruined what was supposed to be a surprise for her with my picture of Colin Farrell, because there is a fixation there. I don't quite understand what it is. Just some other things.
Talented actor.
Yeah, talented actor, yes. There is a lot going on in most organisations. Try and reduce as much as you can at the point you're going live with Epic, just to give people bandwidth and have organisational bandwidth. As Sarah said, make sure you support your admin staff. It's not that they get forgotten, but they are disparate, and sometimes it's hard to support them. So just be thoughtful. As I say, organisational leadership, make sure they're visible, strong governance. And the last one there, really, have fun and be kind. It's a really stressful time, but it can be enjoyable. And in a way, these are just some pictures to finish, really. The gentleman in the pink hat and the mask is actually one of our ENT surgeons. And the guy helping everyone make sourdough is one of our intensivists, both of whom were medical information officers, but they worked with the team. And there's Epic folk on this picture as well as our own internal team. So there's just a few pictures about what we did at Go Live. The last slide, I won't dwell on this because I am conscious we've overrun and there'll be lots of questions. And I've stolen this off Epic. I think this is just to make clear the experience of every organisation is different. The Marsdens didn't quite look like this. This is what we looked at beforehand, and we didn't really reflect this exactly. But people will feel different things in the first weeks following Go Live, and that's completely normal. So to start with, you get this mix of anxiety and actually, you know, people are being optimistic. It's a new system. There'll be lots of issues, but they won't always be difficult. There'll be, I can't log in and I can't do this. As you move through into the few weeks after Go Live, the issue complexity increases. You get stuck with things that really take a lot of thought and teams coming together, and people's batteries run out. And that's partly what this is saying. I think it's just really to be aware that this is not something that happens in the first weekend. There's 6 weeks or so where, as an organisation, you have to accept that it does take time for people to adapt, and just be prepared to support them through that. I will attempt to stop sharing. So apologies, we've gone over a bit, and obviously happy to take questions.
Richard, Sarah, thank you for your candour. Much appreciated. I think my takeaway from that is, and I've heard it from others, that this is the start of a journey, and anxiety levels can peak and trough throughout the journey. So I'd like to hand over and see if there's any questions from any of our 150 plus participants this afternoon. Be surprised if there's nothing. No hands raised.
AHP, Sarah? The AHP experience?
Oh yeah, I can pick that up. So I think, you know, one of the things at the beginning for me was really about setting up a team. And I built a team. I always like to think I built a team on what I think my weaknesses are, and obviously AHPs was not my area and strength. So I have allied information officers, we call them, because AHPIO just seemed to be too long a thing. So we have allied information officers in the team who led on that side of things for me. But yeah, hugely important. They came on the journey with us. We still have what we call APAG now, which is Allied Professionals Advisory Group, and they you know, have a huge input onto what we do. They're really engaged, actually, really engaged group. So yeah, we have a lot of input from our HPs.
Fiona, you have your hand up. Would you like to introduce yourself and ask your question?
Yes.
Hi,
Thank you,
Fiona.
Linda. Hi, Sarah and Richard. My name is Fiona O'Neill. I'm Chief Nursing and Midwifery Information Officer in the Northern Trust. So we are third in the sequence. Really, your presentation was excellent. Loads of information and loads of notes taken. So thank you for that. I just wanted to ask about, you mentioned staff, that when you went live that the system really didn't meet their needs. Could I just ask how you managed that, what way you went forward with that?
Well, it was a mix, if I'm honest. So for some, it was a case of going back sometimes through their managers to understand, you know, because what we didn't want to do was just make changes to the system if actually there'd been leadership decisions around how we wanted staff to work. So sometimes it was an education piece. We had the biggest issue we had was in our, they were the day case areas, but it wasn't really because of day case. Gosh, we have wards where you might have an outpatient, you might have a ward attender, they may be day case, they may actually move it into an inpatient stay. Epic and that transition between an outpatient setting and an inpatient setting is really complicated, and it can be done, but the order, I mean, it almost felt like if it was a Tuesday and you were standing on one leg, you may be able to see the patient, but if not, you couldn't. And I've explained that badly, but it was very complex, the workflow, and our staff really struggled. And particularly the schedulers who were used to saying, on a Monday, we might have 3 kids like this coming into a chair, but on a Tuesday, we'll have them into a bed, and it will be a different care that's delivered on different days. So that took a lot of unpicking, Fiona. It took us a long time. We had to take that away. And in the meantime, we had to try and almost not fudge the system, but give them as much support as we could just to allow them to see the patients. But that meant flooding them with more help in that period, because actually it wasn't their fault that they weren't particularly efficient. It was our fault that the system didn't really support it. So you get a mix. Some things you can fix quite easily. Some things you just have to say to people, bear with us, it will take a few weeks. Other things we say we're never doing it because you're not allowed to do it that way. You know, so it's difficult to give you a single answer.
Was there anything, Richard, you could have done in advance? Or Sarah, sorry, you were going to come in there.
Yes,
No,
we should have tested better. We simply, and when I say tested, it's validation. Testing, Epic did all of the things it was built to do. So Epic wasn't broken or wrong, but it wasn't usable the way we'd given it to staff. So if you said to staff, you can schedule this particular appointment, they could go in and schedule that particular appointment. What they couldn't do was see all the other appointments of all the other things happening on that day, which is what they were used to. And therefore, the nursing staff couldn't work out even who to have on shift that day based on the type of patients that were coming in, which again is how they used to work in, you know, and they had Excel spreadsheets. We went back to Excel spreadsheets in those day units because it was the only way to give visibility for those scheduling teams and the nursing teams. So yeah, testing some of the complicated workflows at the Royal Marsden. The big problem has been the SACT pathway, and it's fine. The prescribers will prescribe in a protocol, but they used to prescribe a whole series of treatments, right? and say, yep, that's fine. Pharmacy could see it. Pharmacy, the aseptics unit could make that up. Because of the way Epic controls it, and it's beneficial, but it's different. And so the pharmacy team suddenly couldn't see it. They didn't know what to prep. So suddenly we had patients whose medications weren't ready for coming in for treatment. So the more you can practice giving humans the system and getting them to try and do what they would normally do, the better to try and iron out those kind of problems.
I think the ones that struggled the most, Fiona, were those that didn't engage in the process. So there was definitely an element of that. And so they hadn't appreciated that some of the workflows had been standardized. And so there is some of that at the elbow training, if you like. We created a huge amount of tip sheets. So and we didn't really mention it, but we used Teams as our communication tool during the go live period. And so if people were struggling, they'd sort of in the Teams chat of what they couldn't find, how to document urine output or whatever it was, and then we'd send a tip sheet via that route, so they had that information available. We did change things at Go Live as well. So certainly from a nursing perspective, how we were documenting fluids and how we were going to do it in Epic was very different. Epic was really built around using unit dose dispensing, which obviously we don't use in the UK, and then using pump integration. So we had to create something slightly different off that. The nurses at the Go Live hated it. And so we pushed forward with them for about a week, trying to get them to do it how we wanted it to work. And in the end, we ended up doing a slightly different build so that they got what they needed, which was how they wanted to document their fluids and how they could see those totals. And it is about weighing up that clinical risk versus, is this just a personal preference? Is this something the whole team wants, or is this just something an individual wants? And so really your information officers plays a huge part in that role. And we were all out in the ward areas just really trying to identify some of those sort of key pieces. Was it an individual, or was it really a clinical risk to the organisation? And that's the way I sort of managed that piece.
That's very helpful. Thank you so much, Richard and Sarah.
Linda, do you want to try and take some of these questions? There's quite a few. I'm trying to read them as we talk.
Yep. I was wondering, were you watching? Can you address Lindsay's one, particularly around the change management piece?
Which one's that one?
Lindsay McKee. Did you provide additional support and training to managers?
Yes. So I'll try and rattle through. For our CTs, they were with us quite early, so the CTs probably got quite good knowledge of the system. We involved them in some of the testing and supporting out to the end users. I think the CTs were reasonably well educated. Super users, we never did what we intended, right? We ran out of time. We did not have the capacity. So for some of our super users, they got more than others, but our super users in the end were supernumerary and not super. And that wasn't because they weren't super people. But the trick that we had, which we didn't know was a trick at the time, because we had our international super users working with our trust super users, actually over a few days, our super users became much more super, because they saw other Epic colleagues or users who knew how to use the system, and they learned very quickly. So the GOSH team provided knowledge of the organization to our colleagues from America and Canada and elsewhere, and they brought Epic expertise. And so our super users did become more super in the few weeks where we had our internationals. But neither at the Marsden nor GOSH did we find the time to truly give our super users the amount of time. Everyone regrets it, but everyone, I think, struggles with the same thing. I think
the change management piece, sorry, I'll pick that one up, Richard. So we had two fabulous change managers within our EPR team. They really were great, but they weren't enough. I think, part of the challenge is getting the right people in the right roles out into the organisation. What we did, we put boards up in clinical areas, so usually in the staff rooms, to be honest, of this is how we document how to order bloods now, and this is how it's going to be in Epic, and just do screenshots so that people could see what was coming. That was really helpful. And we also provided contact numbers for people to get in touch with. But the change management piece is huge, and if I could do my time again, I'd love a change manager in each directorate to really help with that piece. You know, we didn't have that, but as I say, the two we had did a fantastic job. It just wasn't enough.
Our managers, by the way, sorry, our management team at the Marsden, ops managers, I think were much more prepared, better prepared than at Gosh. So, and that was partly a cultural thing, the way in which the Marsden is a slightly different organisation to Gosh, and partly because we were more thoughtful about it the second time round. So did they always know all of the change management approaches? No, but they definitely understood a lot more, enough so that they could ask the right people the right questions. So the more your management tier, however they're structured in the organisation, does understand and owns it. So at the Royal Marsden, the GLRAs, and I don't know who's been involved in those, so the readiness assessments that you do, kind of 120, 90, 60 and 30 days out, they were from 90 days out at the Royal Marsden, they were run by the ops team, supported by our Connect programme team. But gosh, the transition came a bit later, I would say, in terms of operational owners. So yes, we got it better the second time round, not really first. And evaluation of training, I don't think Epic do a kind of a post-live visit assessment of training. So technically there was an assessment of training. I think the Gosh experience was, it didn't tell me everything I needed. I think if you ask the Marsden, they'd say it didn't tell me everything I needed. And I suspect that irrespective of what you do, all of your staff will say training didn't give me everything I needed. And mine and Sarah's view is that it never can, right? So don't expect it to. Set expectations with staff. Rather than saying this training will allow you to do your job on Epic, explain to them that this training will allow them to understand and be able to engage with the system, but it will not teach them everything they need, and that will come in time. And that reduces the anxiety, I think, and doesn't set the wrong expectation with your staff. I just don't think you can do it other than using the system. You just can't learn it, really. That's our view. We may be proved wrong.
We have another question around a transformation team, and what role did they play, if such a thing existed? Well,
we had two change people. Transformation as a concept didn't really exist at Gosh until after the EPR, and I took a board position as transformation director after we'd done the EPR. And that was because Gosh wasn't very good at change. And it then recognised it could do it. So weirdly, Gosh, the EPR go live, the organisation suddenly felt, wow, we can make change. Then we had COVID. So actually that was quite a difficult thing, having stabilised the EPR, and we had a signed off transformation agenda that then got scuppered a tiny bit. But we didn't do, and by the way, the inch deep, mile wide that Sarah talks about, we decided not to try and transform the way in which we did things too much. Some things change just because you're moving from paper to digital systems. We always knew from what we learned from colleagues, particularly Children's Hospital of Philadelphia, who gave us a lot of good advice. If you try and do all your transformation before you understand what this system is and how it will work, you will almost certainly do it wrong. Not all of it will be wrong, but it's very difficult to visualize new ways of working until you're in it. And that was what inch deep, mile wide meant. We took all of the Epic functionality available, but we didn't try and handcraft all of it until we'd started using it.
Okay. This is an important one. Donna's asking, on day 0, did you have rapid onboarding for people who had missed the memo?
Well, no one was allowed to miss the memo. Our chief exec made sure of that. But yes, so we did have that. And at the Marsden, and I saw a question about agency and locums, Gosh didn't have the same problem actually the Marsden had, with more people coming to work, particularly night shifts, who perhaps we hadn't trained. So at Gosh, we trained all of our agency staff that were commonly coming to Gosh before. They were part of our training. We did some of that at the Marsden, but yes, we had a 2-hour training session, so they had some training on the system. So if you're a nurse, you were trained in your core things, same as a doctor. But rather than putting them on an 8-hour training, we had a 2-hour induction, and we had teams, and you've talked about, I think, the IT. We made sure that we had someone that could set up the AD accounts as well as set up the Epic accounts. we asked our HR teams to try and tell us who these people might be before they actually pitched up on the front door, but there was a mixed ability to do that sometimes. But yes, you do need to have a thought out process to rapidly bring people in, both from a AD and Epic login perspective, but also from a training perspective. And you need to agree. Sorry, go on, Sarah.
Yeah, no, I was just going to say your training continues. So we did training, you know, in the 2 weeks post, but we did have a zero tolerance that, gosh, nobody would work if they hadn't had training, and we did actually send a person home because until they'd done training. So and as Richard said, bank is quite different in Gosh than it was at the Royal Marsden. So we just have our own in-house bank. So we were able to get those that had worked in the last 6 months in, get them trained, and then that's how we did it. We paid them to come in and do their training pre. At the Marsden, it was a bit trickier, and it's certainly a lot harder at Frimley Park when we went to go live there. They had on their ITU one night, 50% of their ITU had agency nurses who hadn't had the training, so they had to do that rapid build of training to get people up and running. And it is doable, it is achievable, and you know, it made it safe for the patient. So that's the main thing.
I'm going to grab one question, Linda. Sorry, very quickly. I know you've got no time. Somebody's asked about Southern. You're 2 years away. Can I just say, please ask if any of your staff can go and support Southeastern, because one of the things that you will find by going to a go live and being involved with it is staff get infused by this. Gosh, staff love going and helping now other organisations, as Sarah said. So it's difficult because 2 years is a long time, but if you can encourage staff from the other trusts, Belfast obviously going second in the spring, but all of the trusts to get involved in the Southeast and go live in some form or another, that hopefully will start. I mean, they'll see it will be difficult and hard, and there'll be people in tears, and that will happen, but also they'll start to see what Epic can do for them. And that is really important, because they'll start to want to drive then some of the benefits that they'll see coming to them and to your patients.
And if any of you are in London, reach out.
There is one question that I would like to pick up on. You did talk about, you know, other groups maybe not feeling as directly involved. We have a question around, did you engage with CQC around how that might impact their inspection?
The really interesting
processes.
Conversation, and I can pick that up because I've just come off a call actually with the National CNIO around this. We did struggle. CQC do need educating in how transformational the digital workflow now is, and there have been some challenges around inspections across the UK. And so we are working with our Mark Radford, who is our one of our chief nurses in England, is working with CQC to try and you know, improve that work. So there's an ongoing piece around that, because at the moment it is a bit of a challenge, and you know, they don't see what they expect to see because it's such a different way of working digitally.
We are almost out of time, but I would like to think that we can maybe get some answers to some of the other questions. I knew this was going to be a hot topic whenever they were talking to people who have actually done the implementation. And Sarah, you have an open invitation to visit Belfast anytime. Just let me know when you're on a flight, and we'll make you most welcome and fill your days very easily.
Yeah.
Again, to everybody who participated, thank you so much. We are planning on running a number of these events in the coming weeks. So if there is a group or a person in particular that you would like to hear from that's been involved in an Epic Go Live, please let us know, and we will reach out to teams wherever to see if we can get a lived experienced person to come and tell you what it's like. We'll always pick up a golden nugget from somebody who has actually done this. It is a time of heightened anxiety, but we're doing as much as we can to share as much as we can in advance so that Encompass is as smooth a transition as we can make it. We really do appreciate your input, and again, Richard and Sarah, thanks so much for giving up your Friday afternoon to talk to us. It was much appreciated.
Well, thank you for putting up with us.
Thanks for having us.
Thanks, guys. Thank you.
Thanks.